Assalamualaikum and good evening, everyone. A very warm welcome to all participants joining us today. My name is Dr. Nurul, and it's my pleasure to serve as your moderator for this session. On behalf of the Unit HIV, STI, and Hepatitis C, Jabatan Kesihatan Negeri Johor, I would like to welcome you to the fourth session of our CME webinar series. For those who joined us during our previous CME session, welcome back. And to those who joining us for the first time, we are delighted to have you with us. Before we begin, I would like to share a few housekeeping reminders. Kindly ensure that your microphone remain muted throughout the session. If you have any question, please type them in the chat box and we will address the questions during the Q&A session at the end of the presentation. The registration link for the e-cert will be shared at the end of the program. Thank you for your cooperation, and with that, let us proceed with today's session. This evening, we will be discussing on an important topic titled Hepatitis C, Identifying High-Risk Groups for Timely Testing and Treatment. As Malaysia continues its effort towards the elimination of hepatitis C as a public health threat, timely identification of individuals at risk and early linkage to treatment remain critical. This webinar aims to strengthen our understanding of risk-based screening and the important role healthcare providers play in improving patient outcomes. It is now my pleasure to introduce our speaker, Dr. Mohd Hazizul bin Abdul Samad, an FMS specialist currently serving at Klinik Kesihatan Mengkibol, Johor. Dr. Hazizul obtained his Bachelor of Medicine and Bachelor of Surgery from the Manipal Academy of Higher Education in 2010 and completed his Master of of Family Medicine at University Kebangsaan Malaysia in 2022. He has extensive experience in primary care and has also presented his work at national scientific conferences and continues to contribute actively to the advancement of family medicine. Without further ado, please join me in welcoming Dr. Mohd Hazizul bin Abdul Samad. Dr. Hazizul, the virtual floor is yours.
Bismillahirrahmanirrahim. Alhamdulillahirrabbilalamin. Wassalatu wassalamu ala ashrafil mursalin wa ala alihi wasahbihi ajma'in. Rabbi shrah li sadri wa yassir li amri. Wa tamsani qawli amma ba'd. Assalamualaikum warahmatullahi wabarakatuh. Salam sejahtera, salam Malaysia Madani, salam Haji Johor, KKM. Thank you for joining today's session. So I'll be presenting on the topic of hepatitis C, identifying high-risk groups for timely testing and treatment. So as an introduction, hepatitis C has evolved from being a chronic progressive liver disease into one that is curable. So we have very highly effective oral direct acting antivirals with cure rate exceeding 95%. So however, the greatest challenge nowadays is no longer treatment, it is finding the undiagnosed patient before they develop irreversible liver damage. So during this session, we will focus on identifying the high-risk individual, select the appropriate investigations, and ensure timely linkage to treatment within primary care. By the end of this session, I hope that participants should be able to understand the epidemiology and public health importance of hepatitis C, identify individual requiring targeted screening, choose the appropriate diagnostic investigation, perform non-invasive pre-treatment before the treatment, facilitate initiation of DAA therapy, monitor treatment, recognize response using the SVR, Sustained Virological Response, and recognize patient requiring specialist referral. The objective mirror the patient journey from screening to cure. To appreciate why screening is important, we first need to understand the disease itself. So, as an introduction to hepatitis C is a blood-borne viral infection caused by the hepatitis C virus. At early stage of infection, patients usually remain asymptomatic, but approximately 70% of infected individuals develop chronic infection if left untreated. So chronic hep C can slowly progress over decades to liver fibrosis, cirrhosis, hepatocellular carcinoma, and liver failure. The encouraging message now is that the hepatitis C is now a curable disease with the highly achieving cure rates of antiviral. So the cure can prevent a short-term infection to be cured. Next, we see the natural history of hepatitis C. Referred to as the silent disease because patients remain some of them, up to 30%, may have a spontaneous clearance of the virus itself. by their own antibodies. To extend for persistent infection, which can lead to cirrhosis and even until the levels of hepatitis carcinoma and liver failure. So early diagnosis can intercept this virus during the asymptomatic window and prevent, and this will can help us prevent the irreversible cirrhosis and hepatitis carcinoma. Unfortunately, many are still lost before the gaps in life continue. Even though we have effective cure rates, many lost at different stages symptoms. They have disease until they develop the liver failure. Others may fail to undergo confirmatory testing. Some experience delays in referral or treatment initiation. As highlighted in this slide, this gap mainly healthcare system issue rather than failures of treatment itself. So hopefully by decentralizing hepatitis in primary care, it can sufficiently improve access and patient outcome. Finding patient is the only first step. The main important thing is to retain them in the care. Malaysia has adopted a comprehensive national strategic plan aiming to eliminate viral hepatitis as public health threat. The targets include increasing diagnosis, treatment coverage, while reducing new infection and hepatitis-related mortality. So achieving this goal requires collaboration between hospitals, primary care, laboratories, pharmacies, and public health. Malaysia's national strategic plan aligns with WHO elimination agenda. The pillar includes advocacy, prevention, access to diagnosis, surveillance, and comprehensive care. The targets are ambiguous: 90% diagnosis, 90% treated, 90% reduction in incidence, and 65% reduction in mortality. These targets cannot be achieved by hepatitis alone, and we have to work together, side by side, to make the national strategic plan realized by 2030. To understand why the strategy is necessary, let's look into the global burden and the local burden of the disease. So globally, hepatitis C affects estimated people. Around 399,000 annual deaths occurs mainly due to cirrhosis and hepatocellular carcinoma. And then less than 10% infected individuals historically receive curative treatment. Very low. Definition today is not the lack of effective cure, but it's expanding screening and improving access to care worldwide. Elimination depends more on screening rather than development of new drugs. In Malaysia, we face the similar changes. Significant proportion of people living with hepatitis C remain undiagnosed. Here in Malaysia, the modeling studies estimate that hundreds of thousands of people remain infected and many are still undiagnosed. If active screening is not expanded, we can expect increasing numbers of cirrhosis, liver cancer, and liver-related deaths over the coming decades. The graph on the right demonstrates the projected burden if we fail to intervene early. So this reinforces why we in primary care, the screening is so important to identify the disease and help patients to achieve cure. So how does hepatitis C present clinically? This manifestation of the disease. Hepatitis C often called as invisible epidemic because symptoms usually absent until the advanced disease develops. So early disease may patient may present only with non-specific symptoms such as hepatitis. So chronic infection is also important, associated with important extrahepatic manifestations such as CKD, diabetes, mixed cryoglobulinemia, and lymphoma. The most important message at the bottom is we should screen based on the risk factors, not the symptoms, because symptoms, patient might not have the symptoms at all, but they have the risk factor. So we need to screen the patient based on the risk factor. Risk factors are more reliable than the symptoms themselves. What are the sources of hepatitis C infection? In this slide, we can see that the routes of transmission, we can confirm the route of transmission, and we can differentiate it with the common misconceptions. The primary route of transmission is blood exposure, particularly injecting drug use, blood transfusion before the routine screening prior to 1994, unsafe medical procedures, tattooing with unsterile equipment and needle sharing. The less common transmission may also, we cannot also forget that the less transmission via the sexual transmission. The high risk between in the MSM group and HIV or STI co-infection. Also forget about the vertical transmission from which importantly, hepatitis C is not transmitted through food, water, or casual social contact. Some patients might ask whether the disease itself can be transmitted through sharing the plate, sharing the glasses of water. So we have to educate the patient that this is not transmitted through food or water or casual contact, such as hugging or sharing. My critical message is, in Malaysia, high history of receiving blood products before 1994 should immediately prompt hepatitis C screening. By understanding this transmission is essential because it guides whom we should test. So this slide introduces one of the most important concepts in hepatitis C elimination, targeted case finding. Who should we screen? We in Malaysia, we does not recommend universal screening to all patients who came to our setting. Instead, we adopt a risk-based approach, identify individual with recognized epidemiological or clinical risk factor during routine primary care encounters. Starting from the left, patient with unexplained chronic liver disease and persistently elevated ALT should always be considered for HCV testing. This patient, quite a number of patients we see them for a different disease or different care, but we notice that their liver enzyme elevated. This group of patient needs to screen for hepatitis C. We should also remember children born to HCV-infected mothers, current or former prisoners, healthcare workers including healthcare workers following occupational disaster injury. And on the right side, you can see the key high-risk groups also include current or previous people who inject drugs, men who have sex with men, people long-term hemodialysis patient, and anyone who received blood products before 1994, prior to routine blood donor screening in Malaysia. The key message is simple. Every consultation is an opportunity to ask about risk factor. Screening should be proactive and not symptom-driven. This slide will show the algorithm summarize the entire screening pathways that we have discussed before. Every patient begins with clinical risk assessment. If significant risk factor are identified, the next step is to do the antibody screening using the RDT or ELISA. A reactive antibody does not confirm infection yet. So when the patient who are positive antibody screening, they have to undergo confirmatory test by using the HCV or HCV RNA testing. Once infection is confirmed, the patient enters the care pathway for baseline assessment and initiation of direct acting antibody therapy. You notice the green box on the right. It reminds us that if a reactive antibody only indicates previous exposure and must never be interpreted as lethal disease without confirmatory testing using HCV antigen or HCV RNA. The slide divides hepatitis C investigation into three distinct phases. The first one is screening, where the anti-HCV testing identifies previous exposure. Then the next phase 2, is confirmatory test, where HCV RNA or HCV core antigen confirms active infection. Only after this active infection proven, we proceed to phase 3, which is the baseline assessment before treatment. This assessment includes FBC, renal profile, liver function test, and don't forget about the fibrosis assessment using APRI or FIT4 score that has been widely used in our setting. So the high yield message at the bottom is particularly important. Never perform baseline staging before active infection has been confirmed. Next, we look to the serological assays, the first line investigation that we do to screen the patient. Anti-HCV testing is excellent screen tool because of its high sensitivity. RDT is usually particularly useful in primary care because RDT provide point of care result with minimal laboratory infrastructure, whereas ELISA remains widely used in hospital laboratories due to its high throughput. However, both tests detect only antibodies and not the virus itself. So they cannot distinguish between active infection, spontaneous viral clearance, or previous treated disease. Next, we look into the molecular assay, which is the definitive confirmation of hepatitis C. When the antibody screening is reactive, molecular testing establishes the diagnosis. The gold standard remains HCV RNA PCR, which detects the viral nucleic acid and can be used quantitatively or qualitatively. But in the setting of RNA PCR were not available, Malaysia recognized HCV core antigen as a validated alternative. The important clinical point is that the either test confirms active viremia, allowing treatment to be proceeded. So from practical perspective, core antigen testing improves access, particularly in decentralized. Brings together the interpretation of antibody and confirmatory test results. If both anti-HCV are negative, is about patient has no evidence of infection. But if antibody positive, but A or core antigen is negative, this one usually represent either the antibody was positive result. But the most important is positive with RNA or core antigen, which confirms active chronic hep C infection. So if at this stage, patient should be notified according to distribution immediately to treatment. The flow chart integrates between everything we have discussed before. We start with the risk assessment, followed by anti-CV test. Antibody test fatally infection unless been very recent exposure. The reactive antibody result must proceed to Besides diagnosing Hep C, we have legal responsibility to notify disease under the prevention and control of disease and evidence, resource planning and prevention hepatitis program. Before anything, DDH and antiviral therapy, we should perform a comprehensive baseline assessment. This includes 4 domains, which are the clinical evaluation, symptoms, ongoing alcohol or drug abuse, and comprehensive medication review, followed by baseline laboratory investigation, which includes our FBC, renal function, liver function test, and INR if there are evidence of cirrhosis to score the CHALQ score, which I will talk later. Don't forget about the virological screening, co-infection of Hep B or heavy infection. These two are different approach to our management of Hep C. And lastly, identify the special situations such as pregnancy or severe drug-to-drug interaction. These also have a different route of management. The green box at the bottom highlight important reminder, undiagnosed HBV or HIV co-infection can significantly affect treatment decision and patient safety. The assessment ensures that treatment is safe for the of all of our patients. And the tools are already validated to be used that use routine laboratory parameters. But when available, we can always use transient exploratory fibroscan to provide more accurate assessment of liver stiffness. Liver biopsy remains the gold standard. It's now really required, and it's only reserved only for selective situation. Remember the highlighted message at the bottom of the slide. While fibroscan is the preferred imaging modality, pre and practical workhorses for the centralized hepatitis C in Malaysia because it is widely available in our setting. We look into the first line, the pre score. In our setting, our score is recommended as first line triage tool because it only requires two routine available laboratory parameters. We only need AST and the platelet count. The formula is shown on the slide. We have to understand how to play. Now, pre-score below 1.5 suggests the patient unlikely to have cirrhosis. So, for those patients who have a pre-score 1.5, we can safely proceed with the treatment with direct-acting antiviral. But if the score is 1.5 or higher, this raises concern for advanced fibrosis or cirrhosis and warrants further assessment and for hepatocellular carcinoma surveillance. The key advantage is that APRI is inexpensive and widely available and can be calculated in almost every district hospital and primary care clinic. The second commonly used tool is the second commonly used non-invasive score is FIB-4, which incorporates 4 components of age, AST, platelet count, and ALT. Compared with APRI, FIB-4 generally has better performance for detecting advanced fibrosis. But this score influenced by age. Older patient tends to have higher scores, even without significant fibrosis. As on the slide, FIB-4 below and patient of treatment. Whereas for those and further evaluation. In this slide, we can see we can look into the comparison between the two non-invasive fibrosis scoring system commonly used in primary care. We can use APRI as our first line assessment because it's simple, only requiring AST and platelet. FIB-4 needed more component to be calculated. So in the diagram, the practical message in diagram shows that if the APRI result is clearly low, less than 1, the further calculation with FIFO is unnecessary. However, if APRI falls below into the borderline range of 1 to 1.5, we can calculate the FIFO score to improve diagnostic confidence. This sequential strategy was adopted in the latest Malaysian East trial, allowing primary care providers to safely exclude fibrocirrhosis without routinely requiring fibroscan or liver biopsy. So once cirrhosis has been identified, the next step is to determine whether the patient has compensated or decompensated by using the child-2 score. The 5 parameters of the child-2 score is encephalopathy, ascites, bilirubin, albumin, and IR. Each parameter score between 1 and 3 points. Total score then classifies patient into class A, B, or C. Class A with 5 to 6 points represent well-compensated liver disease. Class B indicates significant functional impairment, whereas class C represents the compensated cirrhosis with poor prognosis. The classification is important because treatment decision, referral urgency, and long-term outcome depend heavily on the patient child-2 score. For child-2 score A, we can safely manage in primary care, but for class B and C, which indicates decompensated liver disease, we have to refer to the tertiary center for the management of Hep C. This slide translate progressive assessment into clinical decision making. Patient with compensated cirrhosis, which is shown on the left side, remain suitable for management within the structured hepatitis C program. we in primary care can initiate treatment according to the national algorithm, while ensuring ongoing 6-monthly surveillance for hepatitis carcinoma and screening for esophageal varices where indicated. In contrast, patients with decompensated cirrhosis, shown on the right side of the box, require immediate referral to hepatology or gastroenterology. The features of jaundice, ascites, hepatic encephalopathy, or previous variceal bleed indicate advanced liver disease, and this patient requires specialized management. The key message at the bottom summarizes the pathway well. Primary care manage non-cirrhotic and compensated liver cirrhosis, whereas any evidence of decompensation warrants urgent tertiary referral. The objective of Hep C treatment extends beyond achieving blood clearance. First goal is to cure the infection, demonstrated by achieving the sustained virological response or SVR12. Successful treatment also prevents progression of liver fibrosis, reduce the future risk of hepatitis carcinoma, interrupt the transmission, particularly among high-risk population, and ultimately, successful treatment improves patient quality of life through better physical health, psychological well-being, and social functioning. These 5 goals reminds us that Hep C treatment benefits both individual patient and public health. Before prescribing antiviral, we should optimize non-pharmacological care. As of any management of any diseases or any condition, don't forget about the non-pharmacological management. Central message is that hepatitis C management is comprehensive and not only medication alone. We should counsel patients regarding transmission prevention first, including avoiding the needle sharing and other blood exposures. Then we have to counsel patient on the last time obesity present. Vaccination can A and B should be offered to susceptible patients together with counseling to improve adherence and long-term engagement in care. Next, before starting the AA regimen, we must always assess for drug-to-drug interaction. This slide outlines the simple 3-step approach. First one is to compile a complete medication history, including prescription medicines, over-the-counter product, and herbal supplements. Then check potential interaction using a recognized resource. Usually, we will use the Liverpool Hepatitis Drug Interaction Checker. Finally, we act according to the color-coded recommendation. The red indicates contraindicated combination that should be stopped or substituted. Amber indicates closer monitoring or assessment required for those patients who's on PPI or specific antiretroviral therapy. The green means the combination is considered safe. Systemic approach greatly improves treatment safety. The main DAR regimen currently available in Malaysia. The 2 most widely used Penceramah regimen relevant to daclotide and sofosbuvir ravidacil. The 2 regimes were administered for 12 weeks. Sofosbuvir daclotide regimen is well established and widely available within the public healthcare system, while sofosbuvir Ravidasvir offers excellent efficacy across all genotypes and is quite cost effective. The last row shows the reminders of the regimen such as Ledipasvir, Abovir, Velpatasvir, or Velcaprevir, Preventasvir. This one usually reserved for specialized indication or selected clinical situation. The overall message is that Malaysia has now has effective simplified DAS option suitable for decentralized hepatitis C care. Evidence brings where everything we have this into fight. We begin by confirming the action using HA and HTG. Decision point is assessment using APRI, followed by FIT4 if the APRI falls between 1 to 1.5. Patients who are non-cirrhotic are suitable for decentralized treatment in primary care using either sofosbuvir daclofenavir or sofosbuvir ravidasvir for 12 weeks. Patients identified as cirrhotic or otherwise high risk should be referred to secondary or tertiary care for specialist management. Treated will undergo HbA1c testing. Undetectable HbA1c at 12 weeks confirms cure, after which patient without this continuous risk require ongoing surveillance and prevention counselling in our care. So, demonstrate that hepatitis C management in primary care is now more practical, evidence-based, and highly achievable. We look a bit into the local evidence with the global standard of STORM-C trial. This study demonstrates that sofosbuvir ravidasvir regimen achieve SPR12 of approximately 97% regardless of the HCV genotypes. It shows the pan-genotypic regimen. Importantly, excellent efficacy was observed in genotype 3, which involved the favorable profile with very few serious adverse events. The key clinical complications shown that at the bottom of the slide is that locally generated evidence very supposed to be available as an effective pan-genotypic treatment option in Malaysia. The quite recent studies, which is the EAST trial, evaluate whether 8 weeks of therapy could achieve outcomes comparable to the standard 12 weeks regimen in non-cirrhotic patients. As shown on the slide, both treatment duration achieve similar SPR12 rates of around 93 to 94% with excellent safety profiles. Although the findings are highly encouraging, the green box reminds us that strategy still awaits incorporation into future national guidelines. It has not been, the 8-week regime is not yet implemented in our guideline. For current clinical practice, we still need to continue the 12-week regimen. Now, this slide shows the comparison of the two regimes. Both regimes combine sofosbuvir as a backbone of the treatment. Sofosbuvir is an NS5B polymerase inhibitor, with daclofenavir and ravidasvir as an NS5B inhibitor, both working two different stages of viral replication. The combination achieves high cure rates while reducing the risk of active. The left side, the sofosbuvir daclofenavir regimen, it is being widely used in our setting for many years now. Standard dose is sofosbuvir 400 and daclofenavir 60 mg once daily dosing, and treatment generally is 12 weeks for patient without cirrhosis or compensated cirrhosis. A patient with decompensated cirrhosis usually require longer treatment or up to 24 weeks, and sometimes it has to be added on with ribavirin. The most important point is that there is a drug interaction between daclofenavir and HIV some HIV antiretroviral therapy. Like efavirenz, it reduces the daclofenavir level, so the dose of daclofenavir need to be increased to 90 mg, which can lead to increase of the effect. But the other antiretrovirals such as the protein inhibitor ritonavir and boosted atazanavir decrease daclofenavir exposure just to 30 mg daily. But on the right side, sofosbuvir ravidasvir, the newer pan-genotypic regimen, standard dose is sofosbuvir 400 and ravidasvir 200. Once daily dosing for 12 weeks, 12-week standard. And with the latest evidence of a new trial, we might have opportunity to give only 8 weeks of 2 months of sofosbuvir ravidasvir. This regimen, the sofosbuvir ravidasvir, it's epic. It has very less drug-to-drug interaction, and there's no dose of patient with HIV Hep C co-infection and vice versa. Patient with diagnosed with HIV testing. Co-infection patient can achieve cure rates comparable to HIV monoinfection when treated with DA therapy. But before initiating treatment, we must carefully review the drug-to-drug interaction between the AS and intravital. Important practical point is that intravital treatment should be continued throughout HIV treatment, and adjustment made only when significant interactions are identified. Usually, we will treat the HIV first with if for those who are newly diagnosed HIV and Hep C co-infection, we will treat the HIV first with heart, and then we start the DAA later once the patient already on heart, and then it's good. Now we have the new regime with this first will HIV has Hep B reactivation. So every patient should undergo Hep B as antigen testing before DAA therapy. Patient with active Hep B active hepatitis B require appropriate antiviral management according to HBV guideline, while liver function should be monitored during and after treatment. So patient with Hep B and C co-infection, we need to refer to our gastroenterology or pathologist to manage the Hep B first, to manage both Hep B and Hep C. The next special population is a patient who has advanced CKD or ASRF. CKD presents unique challenge in management Hep C. As shown on the slide, patient with CKD stage 1 to 3 can actually be managed in primary care using a standard regimen. There's no dose adjustment need to be done. But patient with advanced CKD, stage 4 or 5, or those receiving dialysis should be referred to nephrologists for assessment before treatment selection. What about patient with pregnancy and family planning? DAA actually not routinely recommended during pregnancy because the safety data remain limited. So for women of reproductive age should receive counseling regarding pregnancy planning before starting of treatment. If pregnancy occurs during treatment, management should be individualized with specialist input. The important message is that Hep C should ideally be completed before conception whenever possible. If the Hep C is detected during pregnancy, the treatment has to be deferred until patient has delivered. Even if patient is breastfeeding, it is unsafe to start DAA because it's excreted in human milk and there's no safety data for management for DAA in breastfeeding mother. What about children and adolescents? This slide emphasizes the predatory approach. Children born to mothers with hepatitis C should undergo appropriate testing according to age-specific recommendation. Importantly, as highlighted in the red box, all confirmed hepatitis C cases below 18 years of age should be referred directly to pediatric gastroenterology. We have to co-manage with the pediatric gastroenterologist. Because management in children differs from adult, so therefore it requires specialized expertise. So this timeline summarizes monitoring throughout treatment. We begin with baseline assessment, followed by monitoring of treatment adherence, clinical response, adverse events, and laboratory parameters were indicated. But fortunately, DA therapy is generally very well tolerated. So emphasizing on the spotting adherence rather than managing toxicity. At baseline, we do all check the baseline, which includes the AVT, calculate the fibrosis score, and then counseling to avoid pregnancy, give contraception whenever appropriate. And at week 4, we usually see patient to assess the adherence side effects. Nowadays we really need to repeat the baseline LFT or RP because DA is generally very well tolerated. And then we will see again at week 12 for the end of treatment to ascertain of DAA, and then to reinforce counseling on reinfection prevention. And then the next follow-up will be at 12, where we have to test the Hazizul RNA to confirm the sustained virological response, SVR12. If you are unable to do HCV RNA at 12 weeks post-treatment, there are available alternative where we can do HCV core antigen at 24 weeks post-treatment. This also is accepted as a tools to the cure of the disease. So we can use either SVR12 with HCV RNA or SVR24 with HCV-C core antigen. Although all common, treatment interaction or virological failure can also occur. So this slide divide management into three situations, whether the patient is missed doses, treatment interaction, or true treatment failure or relapse. Occasional missed dose should be managed by reinforcing adherence, whereas prolonged interaction may require restarting or extending therapy. We look into the algorithm of interaction in the next slide. For treatment failure or retreatment, which indicates that SVR12, we may need to co-manage with our gastroenterologist, hepatologist, whether we can restart the treatment, but for the second treatment, it needs to be longer. For example, if we give DA for first time treatment, we give DA for 3. If patient does not achieve, we have to retreat with longer duration of treatment, which is the 6 months regimen, either supposed to be daclofenacin or supposed to be preferably the same regimen as the first one. If you use daclofenacin, we use the same regimen, or we use rovidacin, we use the same regimen. But it has to be co-managed with gastro or hepatologist. So this slide shows how do we manage the treatment interaction. First, we see if patient miss the AA, why the patient miss the AA, we have to ascertain why patient does miss the AA, we have to address the issue. If the interaction occurs in month 1, first month of treatment, if it is occur less than 5 days, or patient only missed up to 4 days, the treatment can be continued and completed until 12-week course. But if the patient does not miss the medication for 5 days and more, we have to restart again the regime from day 1. If the treatment occurs at month 2, whereas patient already completed about 5 to 8 weeks of therapy, the thresholds change slightly. At month 2, if patient the interaction occur at month 2, if it occurs less than 7 days up to 6 days of missed treatment, the medicine can be continued. Okay, treatment continued and then completed as per the 2-week course. But if patient missed the medication for more than 7 days, 7 days and above, he has to be started again, the treatment from day 1. If the interaction occurs at month 3, where patient already completed more than 8 weeks of DAA therapy, we don't really need to restart or continue the treatment. Instead, we have an option to repeat the RNA at 12 weeks after treatment cessation and see whether the RNA is detectable or undetectable. If the HCV RNA is undetectable, we can label patient as HCVR achieved and no need to retreat. But if the HCV RNA is detectable, we have to restart the same regime again, as I explained before. Okay. So this algorithm guides follow-up after treatment. So if SVR12 is achieved and the patient has no cirrhosis, they can actually be discharged from specialized follow-up from follow-up after counseling regarding reinfection prevention. However, patients with cirrhosis should remain in care. They require lifelong surveillance of hepatocellular carcinoma with 6-monthly ultrasound and alpha-fetoprotein and monitoring for completion of photohypertension, special surveillance. The critical message is that SVR cures the virus, but it does not eliminate clinical cirrhosis. For those patients who are non-cirrhotic, although we can discharge them from care, but those who still has ongoing infection, risk of infection, such as those who still injecting drug, we have to return them in our care. We have to do a periodic HCV core antigen testing at least every year. The next slide clearly outlines the situations that require referral. When do we refer to tertiary center? So immediate referral warranted if patient has decompensated cirrhosis with ascites, jaundice, or encephalopathy, or patient has liver failure, patients already carcinoma or suspicious patient unresolved drug-to-drug interaction. As for the on the left side, it shows that we can manage co-management from primary care to tertiary if patient has treatment failure, whereby the SPR was not achieved. Patients who are pregnant, children, adolescents, severe CKD, and HBV co-infection. HBV co-infection usually we can manage in our care setting unless patient has drug-to-drug interaction or patient is not suitable because patient has according to the heart regime. So this is actually my last two slides. This slide summarize the national strategy into 6 interconnected pillars. So like take home message. Okay, Hep C is a curable disease with very good direct acting antiviral which achieve more than 95% cure rates across most population. Then we have to do a targeted screening. We do not wait for symptoms. We have to actively screen individuals according to their risk factors. And then we use available RDT, which is available in primary care, or ELISA, which is mostly used in hospital. This. Once we screen antibodies is positive, we have to confirm the viremia first using HBV RNA or CV core antigen. Then before treatment, we have to assess fibrosis early. We utilize the simple non-invasive calculators, the APRI and FIT4 score at baseline, identify cirrhosis and determine post-SVR pathways. Patient without cirrhosis or fibrosis, we can safely manage with simplified treatment regimens. And the simplified treatment regimens, which is now we have we might go into the 8 weeks of sulfosylphosphate rabidacid in future, hopefully. This one is very effective and require minimal routine lab monitoring. I think that's my last slide. With that, I thank you.
Thank you so much, Dr. Hazizul, for very informative slides. Okay, so we have some questions here. Dr. Hazizul, you emphasize that the hepatitis C is often a silent disease and that the screening should be based on risk factors rather than symptoms. So in your experience, what are the most commonly overlooked high-risk groups in our primary care setting? And how can clinicians incorporate risk assessment into a busy clinic consultation without significantly increasing consultation time?
Sorry, can you repeat?
I
didn't get the.
Sorry. Okay, sorry. So basically, the question is, what are the most commonly overlooked high-risk group in our primary care settings? Since the hepatitis C is often a silent disease, right? Screening should be based on risk factor rather than the symptom itself. So what are the most commonly overlooked high-risk group in our primary care setting?
Okay. Yeah, like I mentioned in my previous slide, I've already mentioned the targeted population, the screening, those with injecting drugs, right? Those who are in prison and history of imprisonment. But some group of patient might have come without any of the risk factors that I mentioned before, but they came with they came for any other reason. They came for NCD treatment. They came for routine. And suddenly when we check, we do screening because we noticed that the LFT is deranged. And then the patient might let us know, might tell us that the patient has a family history of Hep B in the family, right? They say that they mentioned to us that they're concerned about their mother or their sister or their siblings having the disease. So this kind of group might not be in the the risk group, the group that I mentioned before, but we as a primary care, we have to aid them in screen this kind of patient. Another thing is, from mother to children, we don't have we cannot forget about the vertical transmission from mother to baby. That's why we have our PMTCT program, right? But for Hep C, it is not like macam HIV and Hep B now is a routine. It has to be done for all pregnant mother. But for pregnant mother without risk factor, we don't routinely done Hep C. We identify those who came with pregnancy, with those who booking, and we identify the risk whether they have a risk, like pregnant mother who are single mother, pregnant mothers who have multiple partners, or pregnant mother who have who their spouse are single mother. Sorry, their spouse are multiple partners. This kind of group probably another set of group of patient who has risk that we need to look into, and we need to screen them and offer treatment. Other than that, maybe rarely I see in children, like I really see those in children. But I think this kind of group that mainly through my practice, through my experience, this group of patients are mainly those who we help them in screening. Does that answer the question?
Yeah, actually. Thank you, Dr. Hazizul. And another question is, from a practical perspective, what are the biggest challenges faced by primary care clinics in Johor when implementing this pathway, and what practical advice will you give to healthcare providers to overcome these barriers?
Actually, the main challenge I want to say is like because nowadays our last time our challenges is the resource. We don't have much of now we have RDTs widely available, and it's very much help us in managing the disease. But last time we don't have it in all KK setting, right? And then the next, of course, the availability of the medication. Right, before 2019, I think we have to refer all the patients to tertiary for management. But after 2019, we already have availability of the medication, and we can treat in our setting itself. The other challenge is that those who have co-infection, like HIV, we can certainly manage, but Hep B co-infection we have to refer, right? And then other than that, some patient who came with cirrhosis, but but they are very fine. They are clinically well. They are compensated, and we can manage. But sometimes the treatment does not yield in a good give a good yield lah. So we have to refer to the tertiary to co-manage for those with cirrhosis and fibrosis. Mainly about last time it was about resource lah, mainly about the resource, but which is now it's getting improved and improved. We are able to get more and more resources to help us in aiding us in management of Hep C in our setting, in public care setting. I think it's in my perspective, it has those are most challenges.
I believe this will be the last question. From your experience, are there any common misconceptions or mistakes you frequently encounter regarding hepatitis C screening or interpretation of test results?
Can you revise? Can you repeat the question? Sorry?
From your experience, are there any common misconceptions or mistakes you frequently encounter regarding hepatitis C screening or interpretation of test results?
Not much of a misconception, because when we do the screening, we already counsel. We do the pre-test counseling, right? We already explain to the patient about this. Most of the client who we did screening, they actually already understand, already have some knowledge or some idea about the disease. So when we do the test, when we let them know, they actually most of them can accept because we wanted to. It's like macam we counsel them, we educate them, right? We give the pre-test counseling, and then most of them accept that they have it, because I think most of them already knows that about the disease. They know that they already prepared, mentally and physically about the disease. That's why they came to our setting to get treatment. As far as the test is concerned, most of the test is, I mean, it yields good result. It's very, it has a high sensitivity, and I never encounter, I rarely encounter false positive, let's say, apa, screening test lah in our setting.
Thank you so much, Dr. Azizul. So, on behalf of our organizer, I would like to express our sincere appreciation to our speaker, Dr. Azizul. Thank you so much for sharing your expertise that will undoubtedly strengthen hepatitis C management in our daily practice. And we would like to also extend our heartfelt thanks to everyone. Your commitment is truly appreciated. And before we end, I would like to remind everyone to kindly complete the attendance form before leaving the session, as only participants who submit the attendance form will be eligible to receive the e-cert. And I would like to take this opportunity to share some information about our next CME webinar series. We are honored to have Dr. Mohd Firdaus bin Saleh, the Head of Subspecialty Services for Gastroenterology and Hepatology, Ministry of Health Malaysia, and one of our nation's leading experts in the field of gastroenterology and hepatology. His session, titled Accelerating HCV Elimination with Short Course DAA Therapy, will take place on this Friday, 31st of July at 3:15 p.m. We sincerely hope to see all of you again at our next session. On behalf of Unit HIV, STI and Hepatitis C, Jabatan Kesihatan Negeri Johor, thank you once again for your participation and continued support of our CME series. Have a pleasant evening, stay safe, and Assalamualaikum warahmatullahi wabarakatuh.